Oh. Okay. Hello. Let me unmute you. Okay, you can hear me now, Eddie, right? Can you hear me now? Hello, Eddie, can you hear me? Hello? Hello, hello, testing 1, 2, testing 1, 2, testing 1, 2, testing 1, 2, testing 1, 2. Hello? I can't see you, I can't hear you. You need to, can you hear me? You can chat, right? Okay, yeah, hello. Okay, can you hear me? Can you hear me?
Yes, yes, I hear
Oh,
you.
okay, I can hear you. There you go. Okay, go ahead.
Yes,
Okay, I can hear you fine. Now we got to get your camera working. At the bottom of, you using a smartphone or a laptop, desktop?
I will use my laptop.
Are you at the laptop now?
Yes.
Okay.
Yeah.
Okay, at the bottom of the screen, there is a camera on the bottom left, a video camera. You have to open the menu next to that. Do you see that? At the bottom left is a camera and a microphone. The bottom left. Do you see that? It says mute and stop video.
That means I should use my laptop when I join the meeting, right?
Right. You're in the meeting now, but we have to fix your camera. Your camera is not your camera. I cannot see you. So you have to change your settings.
Yeah. Can I change my laptop first, because now I use my phone, so
Okay.
I need to change it.
Okay. Well, you know, I have a conference now from India on the facial nerve. And I have to stay here for another hour. Will you be available in about an hour?
Yeah.
Okay,
yes.
so I text you when I get finished, okay?
Yes.
And you can stay if you want. It's a facial nerve. I don't know if you're interested, but Indian ENT doctor. But whatever you want to do. Anyways, I'm going to talk to you in about an hour for sure, okay?
Yes.
Okay. Actually, I'm going to show you the ENT doc now. That's right.
And its branches, and of course what are the clinical correlations which we are going to deal with in the facial nerve. So these are the broad topics on which we are going to describe this cranial nerve. Okay, right. Now let us go to embryology. So the facial nerve develops from the second pharyngeal pouch. So this is very, very important. And our next episode or lecture is going to be on branchial arches and pharyngeal pouches. So that is going to be on Saturday, right, Pradeep? So Saturday night we're going to have a lecture on branchial arches. That is also a big question for you in MS. So, but this facial nerve develops from the second pharyngeal pouch. So we described the mandibular, which is actually the first arch. The third, the nerve of the first arch is mandibular nerve, and this is the second pharyngeal pouch. It develops from third week of gestation. It develops from third week of gestation. The facial-acoustic primordium gives rise to cranial nerve 7 and cranial nerve 8. So it arises from at the third week of gestation. Main trunk courses into the mesenchyme approaching epibranchial plateau. So now let us see what are the weeks of gestation, how this nerve develops. So in the third week, there is a collection of neural crest cells. So third week of gestation, there is a collection of neural crest cells. The fifth week of gestation, the chorda tympani. So the chorda tympani is the first branch of the facial nerve to develop. So this is very, very important. Many MCQs can be asked in this. Which is the first branch to develop in gestation? The answer to that question is chorda tympani and the greater superficial petrosal nerve, and of course the seventh nerve nucleus. So that occurs in the fifth week of gestation. In the seventh week of gestation, the geniculate ganglion develops and the nervous intermediates. So 3, 5, 7, 8 and 12. 3, 5, 7, 8 and 12. You have to memorize this because this is very important for your viva as well. So in the 8th week of gestation, the nerve to the stapedius develops, and in the 12th week of gestation, all the facial nerve to all the facial muscles develop. So this is the tabular column. You can actually go through it. Now let us see basically when I did my PG, I did it from Madras Medical College. I had done around 80 to 85 temple bones by the end of my MS post-graduation. So you please understand that you can get a hold on the facial nerve only by doing temple bone dissections. Of course, after that, I used to do it every week after my MS, still maybe 1 or 2 years. Now maybe around 500 to 600 temple bones I would have dissected wherever I had a chance. You just have to see one of my dissections. This I have dissected just to show you the facial nerve. That's actually the retrofacial cell dissection. See the facial nerve. That's the vertical segment, and that's the horizontal segment. And you can see that this is actually the vertical segment of the facial nerve which has been dissected there. And of course, you can see the labyrinthine block here. That's the superior canal, the lateral canal, the posterior canal, and this is just to show you the course of the facial nerve. You can see the chorda tympani there, and I'm going to show you just a video here. Of course, this is a temporal bone dissection, just taking off the chorda tympani. You can see the stapes suprastructure very clearly, and you can also see the course of the facial nerve, the horizontal part and the vertical part of the facial nerve. You can see that very clearly here, and you can also see that the labyrinthine block has been clearly demarcated. Of course, we will be showing you a few more dissection videos just to show you an idea of how you have to do the temporal bone dissection and you have to do the facial nerve dissection. So that's just want to show you as a preliminary. Okay, now let us see the functional components of the facial nerve, the nuclei, because this is another very important viva question which the examiners ask the candidates, the MS candidates, the nuclei, the distribution and the function of each segment or the so it has got general visceral efferents, then special visceral efferents. It's definitely got a special visceral afferent and a general afferent here. So we have the first is a superior salivatory nucleus. So this is very important. The superior salivatory nucleus lies in the we are going to describe all this. Don't worry, we will describe all this. The superior salivatory nucleus, but the distribution is towards the submandibular and the sublingual salivary glands. So you have to write general visceral efferent, superior salivatory nucleus. You remember this tabular column. Then it goes to the preganglionic secretomotor fibers. Now let us now describe one by one. I'm just going to go one by one. What are the functional components? The special visceral or the branchial efferent. So SVE, special visceral efferent. The motor axons supply muscles derived from the second branchial arch. So the axons, the axons arises from the neurons just rostral to the pontomedullary transition. So this is very important. Where does this arise from? It's just rostral to the pontomedullary transition. It runs posteromedially, arching over the sixth nerve, the abducens nerve nucleus, to rise facial colliculus on the floor of the fourth ventricle. So this is very, very important. This slide is very, very important, and you have to, be very thorough about this. So this is the only cranial nerve which actually, arcs around the sixth nerve, and it turns anterolaterally to leave the brainstem. So it turns anterolaterally. So this is the first special visceral efferent. The next is the general visceral efferent or the parasympathetic fibers. So it lies in the pons lateral to the main motor nucleus. It lies in the pons. These fibers are secretomotor to the submandibular and the sublingual salivary glands and the lacrimal gland, glands of the nose, palate and pharynx. Now the third is the general visceral afferent. So you have the first is the special visceral efferent. So you should talk about efferent. The next is the general visceral efferent. Then you talk about the special visceral afferent. Fibers carry taste sensation from the palate and from the anterior 2/3 of the tongue except for the circumvallate papilla. Now the next will be the general somatic afferent. So the general somatic afferent, the fibers from the skin of the ear. The nerve does not give any direct branch to the ear, but some fibers may reach it through communication with the vagus nerve. So this is very, very important. Sometimes we call it the nerve of Risberg. You can see here this column. You have to memorize this column. So this is very, very important, and that's why I described all this. What are the components of the facial nerve? It's a special visceral efferent, general visceral efferent, and you have the special visceral afferent and general somatic afferent. So you have to clearly know about that. Now, what are the nuclei of the facial nerve? The fibers of the nerve arise from 4 nuclei situated in the lower pons. So, number 1 is the motor nucleus or the branchiomotor nucleus, lies deep in the reticular formation of the lower pons. So, this is first nucleus, the motor nucleus. The second is the superior salivatory nucleus is the parasympathetic. Third is the lacrimatory nucleus is parasympathetic. A nucleus of tractus solitarius, and it is gustatory and also receives afferent fibers from the glands. So what are the nuclei? There are 4 nuclei. The motor nucleus or the branchiomotor. Second is the superior salivatory nucleus, parasympathetic. Lacrimatory nucleus is parasympathetic again. Nucleus of tractus solitarius. Now let us see this. you're going to see here very clearly, you can see the facial nerve nuclei here. This is the pons, the pontomedullary junction. Just this is the facial nucleus here, which is actually looping around the abduction. You can see how nicely this diagram, you can actually take a slide like this, and then you can draw when you're asked in the nuclei of the facial nerve. You can actually draw it, and you can show it in to your examiner in your paper. So that is very important to so nucleus of tractus solitarius and all this. Now you can see here the motor nucleus. You can see this diagram which shows the nucleus here, that's the abducent nerve, and here is the superior salivatory and the lacrimal nucleus, and this is the facial motor nucleus. See very, very carefully all that. See how the nuclei are distributed. The motor nucleus actually goes around the abducent nerve. The motor nucleus fibers goes around the abducent nerve, and then this is the nucleus of tractus solitarius, and then this is actually the trigeminal nucleus tract, and the nervus intermedius, all this coming here. So this is very important. Now let us again see another diagram, the nervus intermedius. Of course, this is again line diagram showing the same, where the motor nucleus goes around the abducent nucleus. So this is very important for the exam going MS postgraduates. Oh, hello, Dr. Anthony Francis. Professor Anthony has joined us. Thank you, Professor Anthony. The encyclopedia of ENT I call. And of course, what is the motor nucleus? It's the main nucleus of the facial nerve. The motor nucleus, the main nucleus of the facial nerve, lies in the lower part of the pons, and it is lateral to the 6th cranial nerve and medial to the 8th cranial nerve. So it is lateral to the 6th and medial to the 8th, and supplies the facial muscles. What are the facial muscles supplied, and what are the all the muscles we'll be describing? Of course, it also supplies the stylohyoid, the posterior belly of digastric, the platysma, and the stapedius. So what are the muscles supplied by the facial nerve? You have to answer the muscles of facial expression, the stylohyoid, the posterior belly of digastric, platysma, and the stapedius. Okay, now this is another diagram showing that a 3D view of the nucleus going around the 6th nerve and then coming out here. So you can see that very clearly. The superior salivatory nucleus is here. This is the superior salivatory nucleus. This is the motor nucleus of the 7th nerve, and of course this is the abducent, which is here, and then the nucleus of tractus solitarius. You can see that very clearly in this picture. Now, you might be asked a short notes on nucleus solitarius. This is I've seen that in one of the MS exam papers. I think you should know about it. Nucleus solitarius. So a column of gray matter embedded lateral to the vagus nerve. The rostral part deals with taste. You just have to write these. That's it. You will get full marks for if you write this. It's a short notes which I saw it in the exam paper. The rostral part deals with taste. The caudal part deals with GI and cardiorespiratory function. It's dorsolateral to the facial motor nucleus and receives taste sensation from the anterior 2/3 of the tongue. So this is about nucleus solitarius. This is very, very important. And sometimes you might be asked short notes on superior salivatory nucleus, and it lies in the pons medial to the motor nucleus. It lies medial to the motor nucleus in the pons and supplies the secretomotor parasympathetic fibers to the submandibular and the sublingual glands. So this is again a small short notes which can be asked to you. So you can see here again, if you want to draw the diagram, you just draw the mammillary bodies here and then open up. You can see that the floor of the 4th ventricle, and then you can see here the facial motor nucleus, the salivatory nucleus, superior salivatory, inferior salivatory nucleus. This is the abducent nucleus. This is the trigeminal motor nucleus. All this you can see very beautifully in this diagram. You can actually use this for your exam to draw the picture. Now let us talk about the general sensory spinal trigeminal nucleus, and upper part of the trigeminal spinal nucleus, and receives sensation from concha and auricle through vagus nerve, and bipolar neurons from this cell bodies in the geniculate ganglion. This is present in the geniculate ganglion. Okay, motor component forms the largest component of the facial nerve nuclei, and the other 3 components form a distinct facial sheath called the nervus intermedius. So the motor component forms the largest component of the facial nerve nuclei, and the other 3 components form a distinct facial sheath called the nervus intermedius. Okay, now you can see the distribution of the facial nerve. You can see here the internal acoustic meatus is here. If you want to draw the whole facial, you have 4 colors. You should carry your sketch pens when you go to your exams, especially your MS exams. I did that during my MS. I used to draw these it's a very simple motor nucleus of the facial nerve, and then it comes to the internal acoustic meatus and goes like that. So this is the posterior auricular branch, and of course you can just draw the visceral motor, the branchial motor, the special sensory, and the general sensory. You see how beautifully this diagram is fantastic. You can just take 4 different colors in your sketch pen and just draw this for your examiner. Now, course and relationship. How do I make this become bigger? Okay. Now, the course and the relationships. Now, the ingenious pathway of the facial nerve through the middle ear and mastoid adds to its complexity and refinement of middle ear microsurgery. Thus, a thorough knowledge of the facial nerve anatomy along with its multiple landmarks is essential for an accurate, safe and effective surgical intervention in the middle ear pathology. So we are now going to deal with a lot of the slides which are going to be totally about the facial nerve and how this facial nerve is going to be seen during surgery and things like that. So this is what we are going to deal with right now. Now, this is what you have to remember, this chart. You can actually memorize this chart because this is going to be a very, very important chart which can be asked in any of your viva or in your theory exams as well. And this is the chart I honestly feel you should remember. Number 1 is the supranuclear cerebral cortex, and then the brain stem is motor nucleus of the 7th nerve, superior salivatory nucleus of tractus solitarius. So length, there's no length. And then the intracranial part of the facial nerve, meatal segment, you see here, brainstem to internal artery meatus. So from the brainstem till the internal artery meatus, you have 13 millimeters. So it's around 1.3 centimeters. That's where you will have the Obersteiner Riedlich zone. So you have, so we'll talk about that, how the hemifacial spasm is produced. It's here. Now in the meatal segment, it's around 8 to 10 millimeters. Labyrinthine segment is 3 to 4 millimeters. You see, fundus to the internal acoustic meatus and the fundus to the porus. So is around 3 to 4 millimeters. Tympanic segment is around 8 to 11 millimeters. So the mastoid segment is 10 to 14 millimeters, and the stylomastoid foramen to the pes anserinus is around 15 to 20 millimeters. So you should remember this slide. It's very, very important because this has to be actually known by every postgraduate. Every postgraduate should know. They will just, the examiner will just ask you, what is the length of the labyrinthine segment? You should say immediately, spot on, 3 to 4 millimeters. What's the length of the tympanic segment? 10 millimeters. What's the length of the mastoid segment? Is 10 to 14 millimeters, and of course the next is around 15 to 20. So here, the cerebropontine angle segment. Let us deal with every segment. The CP angle segment. The facial nerve leaves the brainstem at the pontomedullary junction. So this also can be asked to you. Where does it leave? It leaves at the level of the pontomedullary junction, about 1.5 millimeters anterior to the vestibulocochlear nerve. So it just in front of the vestibulocochlear nerve. The motor fibers loop around the abducens nerve, which we have already described, forming a facial colliculus in the floor of the 4th ventricle, joined by the nervus intermedius together with the 8th nerve, cross the CP angle. So it crosses the CP angle. So it lies ventral to the 8th nerve. It lies ventral to the 8th nerve. The facial nerve then follows a posterolateral course through the cerebropontine cistern for a distance of around 15 to 17 millimeters to enter finally the porus of the internal acoustic meatus in the temporal bone. So this actually, some people might find it difficult to understand this statement. So what I'm going to do in the coming days is I'm planning to do a live to show you the CP angle segment of the facial nerve, how we deal with hemifacial spasm, and suppose you have an the acoustic neuroma, how we dissect the acoustic in this segment. So I'm going to show you a lot of such videos, but not now, but as we progress on our life, we will do that. Now, the CP angle segment of the facial nerve is 1.8 millimeters in diameter and is smaller than the cochleovestibular nerve, which is actually around 3 millimeters. So the eighth nerve diameter is 3 millimeters at the CP angle segment, whereas the facial nerve is such a thin nerve. Yesterday when I was dissecting the acoustic neuroma, I should make the suction power very, very low. Even if there is a suctioning of that facial nerve, which is very delicate, you can actually cause a facial palsy. A third smaller nerve, the nervus intermedius, emerges between the 7th and 8th nerve. So you have the nervus intermedius in between. Of course, I will show you a lot of such videos in the coming lectures. Now, the nerves are ensheathed only by delicate layer of arachnoid matter. This is very, very important. There is no facial nerve covering sheath in that area. So that is why it's very prone for hemifacial spasm. The microvascular decompression is done for that. So you have the ICA or the pica loop or a dolichocephalic vertebral artery, and that can cause a hemifacial spasm because it actually lacks a sheath there. Absence of connective tissue covering renders them vulnerable in the CP angle tumor during the surgery of the CP angle. Okay, now let us see this intracranial course of the facial nerve. Actually, this is the internal acoustic meatus, and you can see that this is another very, very important question in the exam about internal acoustic meatus. They can just ask you about internal acoustic meatus. Please remember that the internal acoustic meatus has got a fundus and it has got a porus. So some people are always confused. I in fact tested a lot of postgraduates, asked them which is medial, fundus or porous. So they will start blinking their eyes. Please remember this mnemonic prime minister. Prime minister, you will not forget prime minister. So porous is medial. So fundus is lateral. So this is very important because you have to remember certain things with mnemonics. So you can remember prime minister, porous is medial. So here we are, internal acoustic meatus segment. The IAS segment occupies the anterosuperior quadrant of the internal acoustic meatus and measures 5 to 12 millimeters. So you have to draw a diagram of this. They will definitely ask you this diagram. You have to draw this. It's very important. You can see here the anterosuperior quadrant is the facial nerve. You can see here this is the facial nerve, and then you have a Bill's bar. This is the Bill's bar. So Bill's bar can be asked as a separate short notes for you. The Bill's bar. This is the postero-superior area where there is superior vestibular nerve. This is the superior vestibular nerve. This is the horizontal crest which separates the superior vestibular nerve from the inferior vestibular nerve, which is postero-inferior. Antero-inferior is the cochlear nerve. So antero-superior is facial nerve. Bill's bar, superior vestibular nerve. So Bill's bar separates the facial nerve from the superior vestibular nerve. Let us go again here. I'm sorry. So what is the Bill's bar? It is a crest of bone. The Bill's bar hangs in the vertical plane of the internal acoustic meatus between the superior vestibular nerve and the facial nerve, and the latter being anterior to the vestibular nerve. So this is, I'm telling you, a very, very important exam question. Please memorize this and be very thorough. Just young postgraduates who are just going for your MS exams, you have to remember that the Bill's bar separates the facial nerve, which is in the anterosuperior quadrant, from the superior vestibular nerve, which is in the posterior-superior quadrant. Now, the transit zone between the internal acoustic meatus and the fallopian canal is called the meatal segment. So, define the meatal segment. It is the transit zone between the internal acoustic meatus and the fallopian canal. At this zone, the sheath of the nerve is formed only of pia mater and an arachnoid membrane because the dural investment terminates at the fundus of the internal acoustic meatus. So, this is very, 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 very important. So, I told you porous is medial, fundus is lateral. So, the dural investment terminates at the lateral aspect of the internal acoustic meatus. So now this segment of the, ask people to share this with the other Facebook groups. Professor John is asking me, please list the important ENT Facebook groups. There are, I think, some 40 to 50 Facebook groups. I will share that, Professor John. This segment of the facial nerve is the most common site of entrapment during inflammatory disorders of the facial nerve, such as Bell's palsy and Ramsay-Hunt syndrome. So, if you ask in the exam which segment is affected in Bell's palsy and Ramsay-Hunt, you should say this is the meatal segment. So, this is very, very important. So, what is the surgical importance? Close anatomical relationship between the motor root of the facial nerve, nerves intermedius and the vestibulocochlear nerve along their cisternal and meatal portions explain the disturbances in lacrimation, taste, hearing, balance that may result from lesions in the CP angle and internal acoustic meatus. Now, let us go on to the facial canal. The facial nerve enters into a bony canal called the fallopian canal. So, it's called fallopian canal after Gabriel Fallopius. So, this is very important. Why is it called the fallopian canal? It is 25 to 30 millimeters in length. No other nerve in the body travels such a long distance through a bony canal. The fallopian canal is divided into three distinct anatomical segments separated by two genus. So, the facial canal is separated by, so the first is the labyrinthine segment. The labyrinthine segment of the facial nerve is 3 to 5 millimeters long. So this can be a separate short note. Every segment can be asked as a separate short notes for you. If they ask the labyrinthine segment, then you have to write all these points. The labyrinthine segment of the facial nerve is 3 to 5 millimeters long. It is the shortest and the narrowest segment of the fallopian canal, which is 0.68 millimeters. So the shortest and the narrowest segment of the facial canal. Now it lacks arterial anastomotic cascades and it is vulnerable for ischemia. It lies between the middle cranial fossa and extends from the meatal foramen. So it extends from the meatal foramen to the geniculate ganglion. So they'll ask you the extent of the labyrinthine segment. One person asked me about the labyrinthine segment in the question session, Vaishali Kataria Punia. So this is to answer your question. So from the meatal segment till the geniculate, meatal foramen to the geniculate ganglion is the labyrinthine segment. It travels anteriorly, superiorly and laterally, forming an anteromedial angle of 120 degrees with the internal acoustic meatus portion, IAC portion. It lies immediately above the anterior part of the vestibule. So it lies immediately above the anterior part of the vestibule. Right. Now, so what are the points you have to write in the labyrinthine segment? The basal turn of the cochlea is antero-inferior at the genu with superior semicircular canal posterior. So these are all the points you should remember. When the nerve reaches a point just lateral and superior to the cochlea, it angles sharply forwards, nearly at a right angle to the long axis of the petrous bone to reach the geniculate ganglion. Of course, I will show you this in a dissection, so you will understand better when I show you in the dissection specimen. So before reaching the geniculate ganglion, both the facial nerve and the nervus intermedius remain distinct entities and they meet each other just before joining the geniculate ganglion. So just before joining the geniculate ganglion only, the nervus intermedius and the facial nerve meet. So here is a beautiful diagram showing from the middle fossa how the facial nerve is seen. You can see this is the internal acoustic meatus portion. You can see here, that's the IAC. And then here is the GSPN, greater superficial petrosal nerve. This is the first genu, and then you can see the horizontal segment of the facial nerve. And you can see here the malleus, the head of malleus, and then the body of the incus. And here are the superior semicircular canal, the posterior canal, and the lateral canal. See the dissection from above. You can see very beautifully the various the first genu very clearly here, right? Now, the next question which can be asked is the tympanic segment of the facial nerve, or usually I have seen in your exam papers, the MSPGs, they ask about the intratemporal facial nerve. That's the commonest exam question which is being asked in your basic MS exams. So you will have to write all the segments, right from the internal artery meatal segment, labyrinthine segment, tympanic segment, extends from the geniculate ganglion anteriorly to the second genu of the facial nerve posteriorly. So anteriorly from the geniculate ganglion, posteriorly till the second genu. The tympanic segment inclines inferiorly and posteriorly to descend obliquely. Sorry. Along, can you get some water? Yes, along the medial wall of the tympanic cavity, above the cochleariform process. This is very, very important. It's above the cochleariform process and the oval window and below the bulge of the lateral semicircular canal. The second genu of the facial nerve is situated posterior to the oval window. The length of the tympanic segment of the facial nerve varies from 9 to 12 millimeters, and the width of the tympanic segment varies between 1.2 to 1.6 millimeters. In fact, if you look at Shambo textbook, we have referred to several books to make this presentation. If you look at Shambo, he says it can be Daisen in 50%. Out of all the segments, this is Daisen in 50%. So that is very important. The relationship between the facial nerve and the cochlear process is stable and constant. So the more, to me, I think this is a very important Viva question which many of the people will ask you. They'll ask you, which is the segment, which is the most constant landmark? Even if all the landmarks are eroded by cholesteatoma, which will be present? And the answer will be the process cochleariformis. Now, the cochleariform process is resistant to necrosis even in the presence of aggressive otitis media or cholesteatoma. So that's the best and the most constant landmark. What is it? So process cochleariformis. Therefore, it remains a persistent landmark helping to localize the facial nerve. The mean distance between the tympanic segment and the cochleariform process is around 2 millimeters. This is very, very important. What is the distance between the cochleariform process and the tympanic segment? It is 2 millimeters. Now, let us see the endoscopic view. This is the endoscopic view of the right middle ear through a posterior tympanotomy. We have put the endoscope through a posterior tympanotomy showing the tympanic segment of the facial nerve and its relationship with the cochleariform process, a stapes, and so this is the stapes. This is the facial nerve. You can see this is the facial nerve, and this is the process cochleariformis marked in asterisks. You can see very, very nicely, and of course the facial nerve is seen beautifully in this and with an endoscope. That's the attic above. This is the head of the malleus, and of course this is the tensor tympani tendon. Okay, right. Now the next will be the tympanic segment continued, extends from the geniculate ganglion anterior to the second genu of the posterior. This is, I think, a repetition here. I've gone above. This is okay, right. Now this is a very important diagram. I think you will all have to draw in your exam paper. This is what is commonly asked to you, the intratemporal part of the facial nerve. So this is another diagram which you can utilize for your exams, and you can see here the GSPN, the first genu, and then this is the tympanic segment, and then this is the vertical segment. You can see the distance from the lateral semicircular canal is 2 millimeters. The length is 11 millimeters. From the process cochleariformis, it's 2 millimeters. And from the round window, it's 4 millimeters. From the oval window, it's 4 millimeters. So this you can see how beautiful this diagram is, showing a fantastic representation of the facial nerve. Tympanic segment 11, the vertical segment is 15, and then it's going towards stylomastoid foramen. So this shows a beautiful representation of the first genu, the second genu, and the vertical segment of the facial nerve. So you please remember this diagram. Okay, now the mastoid segment is the third segment. It's the longest part of the intratemporal part of the facial nerve. So this again can be a question, which is the longest part in the intratemporal part of the facial nerve, and that is the mastoid segment or the vertical segment. This segment is the vertical, and length is about 15 millimeters. The mastoid fallopian canal is relatively the largest part of the fallopian canal. The nerve fills only 25 to 50% of the fallopian canal lumen at this level. Inflammatory entrapment of the facial nerve is rare in the mastoid segment. So this is very, very important because it fills only 25 to 50% of the canal. It runs vertically downwards in the posterior wall of the tympanic cavity and anterior wall of the mastoid from the second genu just distal to the pyramidal process to the stylomastoid foramen. So what is the extent? They'll ask you from the second genu to the level of the stylomastoid foramen. Now the minimal distance from the annulus tympanicus to the, that is tympanic annulus, to the facial nerve is about 1 millimeter at 9 o'clock position. So that is the closest it will be. And this fact permits to increase surgically the dimensions of the posterior tympanotomy by sacrificing the chorotympanic nerve. Okay, right. Let us see all that. We are going to show so many videos about the dissection of the facial nerve. Now, as the nerve descends inferiorly towards the mastoid tip, it becomes more lateral. It becomes more lateral. In many cases, the inferior portion of the mastoid segment may course lateral to the plane of the postero-inferior quadrant of the annulus. So this is very important. Now, during canaloplasty, the annulus should not be considered as a secure landmark for facial nerve. The facial nerve may pass lateral to the annulus. In such cases, drilling of the posterior-inferior quadrant of the external artery meatus, even lateral to the annulus, may lead to facial nerve injury. Okay, so now I will tabulate and give you all the landmarks of the facial nerve, but before that we will just see how the facial, this is the vertical segment of the facial nerve, that's the choroid tympani, this is the antrum, it's called the antrum threshold angle, this is the antrum threshold angle, this is the short process of incus, you can see that, and then this is the lateral semicircular canal, this is the lateral canal, this is the posterior canal. The posterior canal very clearly seen. This is the ampullary end of the posterior canal. This is the ampullary end of the lateral canal, and you know that the non-ampullary end of the superior canal and the posterior canal meet to form the crus commune. So here you can see very clearly the posterior tympanotomy has been done. The choroid tympani very clearly seen, and of course we will see more of it very soon. The geniculate ganglion. They can ask short notes again of geniculate ganglion. The geniculate ganglion is situated at the lateral end of the labyrinthine segment. So this should be your first line. The pain fibers of the auricular branch and the taste fibers of the choroid tympani synapse with the second sensory neuron at the level of the geniculate ganglion. Second statement. Third statement is secretomotor fibers to the lacrimal gland pass through the geniculate ganglion and form the greater superficial petrosal nerve. So how does it form? Of course, we are going to talk about ganglions in ENT. So in that you will get the pathway, all the pathways it's going to be a separate lecture for you on ganglions and ENT. That's again important short notes in MS exam for you, and we will be dealing with that very soon. Now let us go on to, at the level of the geniculate ganglion, the facial nerve takes an abrupt posterior direction, forming an acute angle of around 40 to 86 degrees between the first and the second segment of the facial nerve, and this is the first genu of the facial nerve. So at the geniculate ganglion is the first genu. The geniculate ganglion is dehiscent in 15% of temporal bones, a condition which makes the facial nerve vulnerable to injury during middle cranial fossa surgery. Okay, now you can see here, this is the facial nerve, the internal acoustic meatus, and then this is the geniculate ganglion. You see how it's going at an acute angle here, it turns here, and that's the greater superficial petrosal nerve, and here is the tympanic segment, and then this is the mastoid segment. Here is the nerve to stapedius, and this is the choroid tympani. We will be talking about all this very soon, and of course we will be dealing with every branch of the facial nerve. Now, the second genu. So we talked about the geniculate ganglion, the first genu, and now we are going to the second genu. The second genu is the junction between the tympanic and the mastoid segment of the facial nerve. So here is the second genu. Here is the second genu. Exactly here. I don't know if you can see the cursor, but here is the second genu. Now, junction between the tympanic and the mastoid segment of the facial nerve, just lateral and posterior to the pyramidal eminence. So where is the pyramidal eminence? This is the pyramidal eminence. You can see here in this the diagram, the pyramidal eminence is here. It is just lateral and posterior to the pyramidal eminence. the facial nerve changes its direction and course inferiorly about 2 to 3 millimeters to form an angulation of about 90 to 125 degree called the second genome. So this is very, very important. They'll ask you how much degree turn it takes in the second genome. The answer is 90 to 125 degrees. So all these have been taken from standard textbooks. So you can actually quote the books also. I'll give you all the books from which we have taken these statements. So you can definitely quote this lecture, definitely. The second genome lies inferior to the lateral semicircular canal and medial to the short process of incus. So tell me two landmarks of the second genome: lateral semicircular canal, short process of incus. The mean distance between the short process of incus and the second genome is a relatively constant relationship, and it measures around 2 millimeters. So the distance between the short process of incus and the second genome is a relatively constant landmark. It measures 2 millimeters. It's very, 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 very important. The second genome of the facial nerve is the most susceptible portion of the nerve to suffer from an iatrogenic injury. So this is another question which can be asked. Which is the commonest site of iatrogenic injury during ear surgery? The answer is second genome, because it is not visible before identifying the nerve itself, especially in case of invasive cholesteatoma and granulation tissue. Knowing that the second genome is located inferior medial to the adytus, the nerve could be at risk of injury while drilling towards the adytus. Especially, I've seen some postgraduates when they drill from medial to lateral, extend the adytus, they want to widen the adytus, the burr can actually damage the second genome. Now, we will go on to, oh my God. The greater superficial petrosal nerve. So this can be again asked as short notes. Secretomotor branch of the facial nerve. It emerges from the anterior upper portion of the geniculate ganglion. It carries secretory fibers to the lacrimal gland. The perigeniculate area is the weakest zone of the Fallopian canal. It is the most common localization of traumatic facial nerve injury in temporal bone fractures. So this is another important question which can be asked. So they will ask you, which is the commonest localization of traumatic facial nerve injury in temporal bone fracture, and the answer is at the level of the first genome. The greater superficial petrosal nerve represents an important landmark for facial nerve identification during middle cranial fossa approach. Now let us go on. In the middle cranial fossa, the GSPM passes deep to the Gazinian ganglion to reach the foramen lacerum, where it enters the pterygoid canal. So, the greater superficial petrosal nerve joins the deep petrosal nerve, which is actually the sympathetic plexus around the carotid artery, and both of them join to form the median nerve, or the nerve of the pterygoid canal, which actually gives all the secretomotor, which forms the pterygoparatine ganglion. So, which is actually secretomotor fibers to the lacrimal gland. In the pterygoid canal, the GSPN joins the deep petrosal nerve to become the nerve of the pterygoid canal, or the Vidian nerve. The Vidian nerve traverses the pterygoid canal, then the sphenoparatine ganglion, and where the sensory fibers have their cell bodies. These fibers are distributed to soft palate and to the tongue. Okay, nerve to stapedius muscle. It arises opposite to the pyramid of the middle ear. So it arises opposite to the pyramid of the middle ear. Supplies the stapedius muscle. Stapedial muscle, what is the function? Dampens excessive vibrations of the stapes, and if it is paralyzed, it causes hyperacusis. So nerve to stapedius muscle. Now, this is another short notes which you can actually get in your MS exam. The chorda tympani is the terminal branch of the nervus intermedius. It's a terminal branch of the nervus intermedius. The chorda tympani leaves the mastoid segment of the facial nerve at a variable level about 5 to 6 millimeters above the stylomastoid foramen. So this is another very important question which the examiners can ask. They'll ask you what is the distance between the stylomastoid foramen and the origin of the chorda tympani, and you have to answer 5 to 6 millimeters. The facial nerve and the chorda tympani emergence form the plestus cordofacial angle, which varies between 26 to 35 degrees. So they can ask you short notes on Plesster's cordofacial angle. So what is the Plesster's cordofacial angle? You have to say 5 to 6 millimeters above the stylomastoid foramen. The chorda tympani emerges from the facial nerve and it forms an angle which is around 26 to 35 degrees, which is called the Plesster's cordofacial angle. So this is the answer to the question. Now the chorda tympani enters the middle ear through the caudal eminence. It passes between the incus and the handle of malleus above the tensor tympani tendon to exit through the canal of huge ear, which is in the anterior wall of the middle ear. So this is very important. How does it emerge out? Through the canal of huge ear of the petrotympanic fissure. This is very, very important. The chorda tympani passes on the medial surface of the mandibular fossa to finally join the lingual nerve in the infratemporal fossa. So I think we discussed this in the previous episode of the mandibular nerve, where the chorda tympani joins the lingual nerve. And you all know what the lingual nerve is. It's I told you blia, B-L-I-A. So remember all that. The first episode, please go through that. It's all in my Facebook timeline. I will not erase any of these classes. So welcome Dr. Prakash Munka. He is like my brother and is a great ENT surgeon from India. And I really welcome you, sir, for this wonderful episode of Coffee with Janki, episode 2 about the facial nerve. We are discussing all about the facial nerve. Here we are. So this is the facial nerve. Just have a look at this cortical mastoidectomy and also the posterior tympanotomy which has been done. So it's called the Plesster's cordofacial angle. This is the Plesster's cordofacial angle. You can see here very clearly. This is the short process of incus. This is actually the posterior tympanotomy. In cochlear implants, this is what we do. We are also going to have a lecture on cochlear implants. I will show you some beautiful videos. We do cochlear implants very regularly in our center. So most of you might know me as only a rhinologist, but believe me, I do a lot of ear surgeries every day. So I just want to tell you that we do all kinds of surgeries in Royal Pearl, mostly ear surgeries. So this is our prime a bulk of surgeries which we do at Royal Pearl. So this is the incus, the lateral semicircular canal is here, and of course the mastoid segment. Okay, now you can see the chorda tympani. If you're asked short notes on chorda tympani, I already told about it, but you can draw this diagram and you can show that's a facial nerve, the Plesster's cordofacial angle, and then you can see that going through that anterior canal of huge ear. This is the canal of huge ear, and then it joins with the lingual nerve. You can see, you can show them that. Okay, now mastoid segment identification during mastoid surgery. This can be again a short notes for you. Exposure to the facial nerve is done through a cortical mastoidectomy. The most important landmarks for identifying the facial nerve in mastoid cavity are: number 1, horizontal semicircular canal. Dr. Prakash, I may not be able to use the pointer. I'm using the cursor, but it is not seen in this Facebook Live. I'm really sorry for that. So I'm sure that, I mean, it will be useful, but I'm sorry, I'm not, the cursor is being used by me, but it is not showing there. I'm sorry, Dr. Prakash. So I understand, Dr. Matthew Jackson, that I have to point it with I am trying to do that with my cursor, but you're not able to see that in the live. I'm sorry, I'm not able to replicate that. So you will have to, go through the diagram. I'm sorry, I don't know. I don't have a way to actually point it. So exposure of the facial, I'm using the cursor anyways. So exposure to the facial nerve. So what are the landmarks to identify the facial nerve in mastoid surgery? Number 1 is the horizontal semicircular canal, the short process of incus, and the digastric ridge. So the digastric ridge, it's very, very important. So I'm going to do a complete temporal bone dissection for you. I will show you each and every structure in the temporal bone. That will be done as a separate class for you, and I will try to give that as a A to Z of the temporal bone dissection. But you have to remember this for the theory. You should talk about digastric ridge for the vertical segment, and then you have to talk about the short process of incus. The distance is 2 millimeters, and the horizontal semicircular canal. The axis of the seventh nerve corresponds to the axis of the short process of the incus. The nerve is best identified by first imagining a line that begins just anterior to the inferior portion of the lateral semicircular canal and travels in inferior direction towards digastric ridge. So this is one thing which I commonly teach my residents. I ask them to draw a line from the lateral semicircular canal till the level of the digastric ridge. So that's an imaginary line, but that marks the facial nerve. So Prakash Munka sir has commented, I want to see, okay, no problem, otherwise also it's a feast, please change the color of the cursor, maybe use it. Oh, okay, actually this cursor is actually black, you can easily see that, but I'm sorry it's not being shown in the live. I'm sorry about that. So this is already a different color. No, I'm trying to do this for many times, but I think the Facebook live doesn't allow the cursor to be shown, Dr. Prakash Munka sir. So bone of the external ear canal is progressively thinned in a direction parallel. Whenever you drill above the nerve, you have to drill parallel to the nerve until the white sheath of the nerve is identified. Sometimes you can see the arterial plaquette also. You will have something called the pilot bleeding also. So in fact, there are two questions which will be asked to the postgraduate. One is, what is the facial ridge? What is the facial bridge? This is a very, very common question which is asked by the examiners. What do you mean by facial bridge? What does it bridge? So the answer to it is that the facial bridge is called bridge because it bridges the anterior and the posterior buttresses. So anterior buttress with the posterior buttress, it bridges, and that is why it is called the facial bridge. What is the facial ridge? It is that portion of the bone which is lateral to the vertical segment of the facial nerve. So that is the facial ridge. So definition of the facial ridge and the bridge. This is commonly asked by examiners. The drilling must be always done along the lateral aspect of the nerve, not behind and medial to the fallopian canal. So this is, yeah, that's right. That's right, Dr. Sanjeev Yadav. Okay, right. Now, the posterior auricular nerve turns backwards and upwards between the mastoid process and the auricle. It supplies the posterior auricular and the occipital muscles. So the next muscle which is supplied is the stylohyoid. Stylohyoid is supplied by the nerve to stylohyoid. Digastric is supplied, posterior belly of digastric is supplied by the facial nerve. So the anterior belly of digastric, anybody can type the answer. Well, I did a episode on that. Can anybody type which nerve supplies the anterior belly of digastric? Let it be a small prize question for you. If anybody can type. Many people are watching. There's a huge crowd watching this. Maybe at least 400 to 500 people definitely watching this. So if anybody can type which supplies the anterior belly of digastric, I'll be very happy. Now, these are two important things you have to remember: the facial recess and the sinus tympani. So this is again exam question: facial recess, sinus tympani. So the group of cells seen lateral to the second genome of the facial nerve in the upper part of the vertical segment of the facial nerve, and it rarely exceeds around 2 to 3 millimeters. Now superiorly it's bounded by the fossa inquiris, laterally by the chorda tympani, medially by the proximal part of the vertical segment of the facial nerve, and anteriorly the annulus. So you have to remember these boundaries. Correct. So the mandibular, but what is the nerve, specific nerve? Can you tell me, Dr. Naveed? Okay. Now indications is cochlear implant insertion. The facial recess approach is for cochlear implant insertion and also facial nerve decompression. So let us see one. The bone, yeah, correct. Inferior alveolar nerve, Helicobacter pylori. Wow, what a name. So you can see here that I am now drilling off the labyrinth, and I'm just doing a dissection. I have so many videos on temporal bone dissection. just to teach my fellows and residents. So I'm just showing you that's the vertical portion. This is the horizontal portion. These are all dissections we used to do almost every other day in our hospital, Royal Pearl Hospital. We train our fellows. They do a lot of temple bone dissections. Of course, now the wet bones are not available. You'll have to buy that. But we have a temple bone lab here. So we have a very good high-end microscope and also TV monitors to dissect the patient, the temple bones. So, but now you can see that I'm drilling off and I'm just doing a translab approach, and I'm just trying to delineate the labyrinthine segment of the facial nerve. And how is it seen? It is seen like this. You can see here, I'm doing a dissection here. We have opened up the vestibule. That's a sigmoid sinus here. This is the dural plate here. This is the vertical, the horizontal segment of the facial nerve. And let us see how the labyrinthine segment of the facial nerve is seen. You can see here, and everybody should perform this exercise. I honestly request all the postgraduates to do wet temple bone dissections before they perform any mastoid surgeries. I honestly believe that we have to learn on the temple bones. You can see here the vertical segment, the horizontal segment, and of course I think we'll be seeing the labyrinthine segment as well. So you can see here how nicely the superior semicircular canal is seen, the crus commune, the posterior canal, the vestibule is here. That's the sigmoid sinus here, the plate here, the sinus plate, and of course I've done a little bit of the retrofacial dissection, and these are all some dissection specimens. Now let us now see. Of course, we'll be performing one temple bone dissection as a live workshop for you, for sure. Now, let us go on to radiological anatomy. So this is very, very important actually. So we do an axial CT scan to see the facial nerve, and you can see here, oh yeah, Matthew Jackson is right, the mylohyoid branch, and Disha Methwani also gave the right answer. Inferior alveolar nerve is the right answer. Now you can see here. So remember this very important statement which I make when you see, many of you would be definitely knowing how to read a CT of the mastoid. I just want to tell you a very small point here. Anything anterior to the internal acoustic meatus is all about the cochlea. Anything posterior is all about the semicircular canals and the vestibule. But here you can see very clearly the labyrinthine segment of the facial nerve and the anterior genu and the geniculate ganglion. Of course, the central segment, we usually, I always look, if I look at the T2 Fiesta, so these are all heavily T2 weighted images of the MRI. It's called the T2 Fiesta image, and if you look at that, you will always look like a banyan tree. So just look at the banyan tree. This appearance you can never forget, and you can see beautifully the facial nerve with the 8th nerve, the 7th and 8th nerve complex. You will see like a tree, and you will see something like going, this is something which I always have a look, because we do a lot of microvascular decompression at the center. So you have to look at the T2 Fiesta image. So that's very important. Now, this is I told you it's looking like a tree here. This is the ICA loop. You can see the ICA loop going around the cisternal segment of the CP angle, and that's now I just want to show you some images how you can see the facial nerve in the axial CT scan. That's the internal acoustic meatus. You can see the internal acoustic meatus. Of course, the axial and the coronal should definitely be done, and you can see in the CT scan how you can read the facial nerve. I'm showing it with a cursor, the crista falciformis. This is the crista falciformis, and you can see that's the crista. This is the vestibule, and of course this is the cochlea here. So very clearly seen on the CT scan here. That's an axial image to show the internal acoustic meatus, the cochlea here, the fallopian canal, and of course the anterior genu of the geniculate ganglion. Very clearly seen in the CT scan. Of course, here that's the part you can see. Like I always look at the R. So if you write the R like a Roman R, you can see very beautifully, that's the segment where the labyrinthine segment turns into the horizontal segment. That's the geniculate ganglion here. This is a geniculate ganglion, and that's like looking like an R. So you can see here, that's an inverted R maybe, and that's how you look for that segment, very beautifully seeing facial nerve. So that is something which I always remember. This is the signet ring appearance, and you can see here the tympanic segment, very clearly the tympanic segment of the facial nerve, very clearly. That's the signet ring appearance here. And of course the ice cream cone appearance also there. The tympanic segment very clearly seen here in the coronal cuts. And of course, I usually read the facial nerve on the scan by seeing the first thing I see in a CT scan is the styloid process. I'm sorry, styloid process. So I see the styloid process, and then I go up. From below upwards is easier to read the facial nerve. I go one step above, and you can see the stylomastoid foramen. So this is how I usually follow the facial nerve. You can have your own method to follow the facial nerve. I usually follow it from the styloid process, and then go up, see the stylomastoid foramen, and then keep following the slices upwards, and I can trace the whole of the facial nerve. This is again the geniculate ganglion, the greater superficial petrosal nerve, which is seen beautifully here in this CT scan. You can see that. So just a few words about how to read the CT scan of a facial nerve. Okay, now let us go on to extracranial course. The facial nerve crosses the lateral side of the base of the styloid process. It enters the posteromedial surface of the parotid gland, runs forwards through the gland, crossing the retromandibular vein. It crosses the retromandibular vein. It's called a Patty's fascio-venous plane. So please remember that. You might be asked a question called Patty's fascio-venous plane in your exams, and the external carotid artery. Behind the neck of the mandible, it divides into its 5 terminal branches, which emerge along the anterior border of the parotid gland. So within the facial canal, what are the branches? Number 1, greater superficial petrosal nerve, nerve to stapedius, and chordotympani. And it exists from the stylomastoid foramen, posterior auricular, digastric, and the stylohyoid. So this is a very important, again, a question: what are the branches within the facial canal and in the stylomastoid foramen? And of course, terminal branches of the parotid are temporal, zygomatic, buccal, marginal mandibular, and cervical. So the 5 branches, you have to remember all these very, very, very clearly. Okay. Now, you can see here, if you want to draw the facial nerve completely here in the face, you can just draw the cervicofacial and the zygomatic or temporal branch, and how it divides into temporal, the zygomatic, and then the buccal, and then you have the marginal mandibular. Of course, you have the upper buccal and the lower buccal, and then the marginal mandibular and the cervical branch of the facial nerve. Now, the terminal branch is the stylomastoid foramen. The main trunk enters the substance of the parotid gland. The first separation into the upper and lower division usually occurs behind the mandible. Of course, we are planning to show also the parotid gland dissection in another classroom. We will do that. The upper division is the temporal, zygomatic, and upper buccal. The lower division gives our lower buccal, mandibular, and the cervical. This you can easily remember, very easily, and you can say temporal, zygomatic, buccal, mandibular, and cervical. Sorry. So these are the 5 branches, the terminal branches of the facial nerve. Of course, I'm not going to describe each branch. This is will consume a lot of time. Now, the lesions of the facial nerve. You can see here that's a supranuclear lesion, and you can have a nuclear lesion, CP angle lesion. You can have a lesion in the labyrinthine segment, and then suprastapedial segment, supracaudal segment, infracaudal segment. There are so many. You can draw these cuts. If they ask lesions of the facial nerve, just remember this diagram. Just draw these cuts, and then you have to explain how will you test for all these lesions. So that's what you're going to describe now. Now, site A, above the stylomastoid foramen. This, it causes Bell's palsy, which presents as loss of motor functions of all the muscles of the facial expression, leading to the deviation of mouth towards normal side, inability to close the mouth and eye, and accumulation of food, the vestibule of mouth, flattening of expression lines. Side B is above origin of the chorda tympani. All the signs and symptoms of lesion A, that is Bell's palsy, plus decreased salivation. So if there is decreased salivation, the site of lesion is above the chorda tympani. And the loss of taste sensation in the anterior 2/3 of the tongue. Now, site C is above the origin of the nerve of stapedius. All the signs and symptoms of lesion B plus hyperacusis. It's so easy. I made that tableau. I think Dr. Pradeep has made a fantastic tabulation of all this. Site D is at the geniculate ganglion. All the signs and symptoms of lesion C plus loss of lacrimation. See how simple it is. So that's it. So what is the blood supply of the facial nerve? Very important question. Anterior inferior cerebral artery, at the cerebroportile angle, the labyrinthine artery, branch of the ICA, and within the internal acoustic meatus, the superficial petrosal artery, branch of the middle meningeal artery at the level of the geniculate ganglion and nearby parts, then the stylomastoid artery, which is a branch of the posterior auricular artery. This can be asked to you. What is stylomastoid artery a branch of in the Viva? And the answer to it is, it's a branch of the posterior auricular artery, which is again a branch of the external carotid artery. Posterior auricular artery supplies the facial nerve at and distal to the stylomastoid foramen, and the venous drainage parallels the arterial blood supply. Okay, now let us go on to landmarks. This is again a very, very important question, which again and again I emphasize on. This is again will be asked in your exam. So what are the landmarks of the facial nerve, the midlear and mastoid surgery? Number one is the process cochleariformis. The most standard landmark is the process cochleariformis. The second is the cork. What is the cork? Define the cork. They might ask you, what is the cork? It's a bony ridge which hangs from the tegmen anterior to the head of the malleus, useful in identifying the first genome. Now, the oval window, the facial nerve runs above the oval window and posterior segment of the horizontal part of the facial nerve. So these are all the landmarks. Number 4 is the lateral semicircular canal. Number 5 is the pyramid. Pyramid also, the nerve runs behind the pyramid. The second genome is lateral and posterior to the pyramidal process. Now, the retrofacial hair cells helps in delineating the medial aspect of the vertical segment of the facial nerve. So, tympanomastoid suture, they'll ask you, is the tympanomastoid suture a landmark? Yes, the tympanomastoid suture, facial nerve runs 6 to 8 millimeters medial to the tympanomastoid suture, and in vertical or mastoid segment, nerves runs behind the suture. So digastric ridge, the nerve leaves the mastoid at the anterior end of the digastric ridge. So now in the mastoid surgery, what are the pointers? Number 1 is the tragal pointer. We all know the nerve lies 1 centimeter deep and slightly anterior and inferior to the pointer. Cartilaginous pointer is a sharp triangular piece of cartilage of pinna and points to the nerve. That's called the tragal pointer. Now the tympanomastoid.
This is not parotid.
That's for parotid surgery, yes, that's right. Number 2 is the tympanomastoid suture. A nerve lies 6 to 8 millimeters deep to the suture. The styloid process, the nerve crosses lateral to the styloid process, posterior belly of digastric. So 2 important landmarks if you are asked. Number 1 will be the tragal pointer, second will be the posterior belly of digastric. In between both, you will find the extratemporal part of the facial nerve. You see how the facial nerve is seen very nicely, the extratemporal part of the facial nerve. Okay, now differences in anatomical relationship of the 7th nerve in adults and children. In a child, absent mastoid process, incomplete tympanic ring, chord tympani may exit through the stylomastoid foramen. In adult, mastoid process present and tympanic ring complete by adolescence. Then in child, second genu is more acute and lateral. In adult, second genu is less acute and medial. In child, the nerve after exit from the stylomastoid foramen is more anterior and lateral, whereas in adult, nerve trunk is less anterior and deeper. In child, the nerve is very superficial over angle of mandible. In adult, nerve superficial over deep over the angle of mandible. Not superficial, I'm sorry, it's deep over the angle of mandible. Now, what are the classifications of nerve injury? This will be asked to you about the Sunderland classification. Types of nerve injury, just memorize it. Partial block is neuropraxia. Loss of axons, endoneural tubes remain intact, it's axonotomesis. Grade 3 injury, injury to the endoneurium, neuronotomesis. Grade 4 injury, injury to the perineurium, in addition to above is partial transection. And grade 5 injury, injury to the epineurium, in addition to above is a complete transection. The first 3 degrees are seen in viral inflammatory disorders, while 4th and 5th are seen in surgical and accidental trauma. Very, very important. This classification can be asked for you. The second will be the Seddon's classification. This can come as a short notes to you for classification of facial nerve injuries. You have to write about the Sunderland classification and the Seddon's classification. You see the neuropraxia, axonotomesis, neuronotomesis. Now, the clinical lesions of the facial nerve can be supranuclear lesions past the upper part of the face. You all know this, the LMN and UMN palsy. How will you differentiate? This will be another exam question to you. The nuclear fibers supplying the muscles to the upper part of the face are innervated by the corticonuclear fibers of both the cerebral hemispheres. In the supranuclear lesions, only lower half of the face on the opposite side is paralyzed. In intranuclear lesions, involve whole of the face on the same side. The signs and symptoms of intranuclear lesion differ according to the site of the lesion. Now, this is very, very important. This tabular column, you have to memorize this. The supranuclear, intranuclear palsy, forehead intact, total facial palsy. So you can just see what are the points. If you want, you can actually take a freeze photograph of this, and actually you might be asked a question, differences between the supranuclear and intranuclear palsy. Now, what are the causes of facial paralysis? Of course, the central cause, the intracranial cause, the intratemporal cause, extracranial cause, and systemic diseases. All this you can actually read it in any book. And what are the approach, the history taking, the physical findings, and the investigations. But another classification, again, you have to remember, is the House-Brackmann's facial nerve grading system. Grade 1, grade 2. Grade 1 is normal, grade 2 is mild dysfunction, grade 3 is moderate dysfunction, grade 4 is moderately severe dysfunction, grade 5 is severe, and grade 6 is total palsy. So here you should know about what is the movement of the eye, the mouth. So you can actually memorize this classification, House-Brackmann's grading. You generally remember that in grade 1 it is normal, and grade 2 slight weakness noticeable on close inspection. The slight synkinesis will be there in grade 2. Grade 3 is obvious weakness but not disfiguring. And of course, the movement of the forehead, eye, and the mouth you can see here, and you have to know about the House-Brackmann's facial nerve grading. Now, the grading, what are the caveats of House-Brackmann's facial nerve grading system? It's not a perfect grading system because of the problems of inter and intra-observer variations, applicable only to disorders of the facial nerve proximal to the pes anserinus, and not appropriate for single branch injuries. This can be asked as a viva question to you. Now, what are the topognostic tests for facial palsy? They will definitely ask these questions. This question comes in so many exam papers, in MS papers. Schremer's test. It is actually a tear test, and it is semi-quantitative method of comparing lacrimal secretions on normal and affected side. And you take a 5 centimeter strip, which is 5 millimeters of filter paper, And if there is decrease in lacrimation of 75% or more as compared to the normal side, then it is positive. So I'm going to show you the shimmer. This is the shimmer's test. You keep it like this, the plotting paper here, and you compare the lacrimation on the affected side versus the opposite side. The second will be a stapedial reflex testing with an impedance audiometry. If absent, site of lesion between the geniculate ganglia and the. I already described this. If present, then site of lesion is distal to the stapedius muscle. The third would be the taste testing, and you have to do it with either the salt, bitter solution on the lateral aspect, anterior 2/3 of the tongue towards the tip, and you can also do it with the electrogustometry. And of course, submandibular gland flow, and by cannulating the duct, and salimetry 6% citric acid, 25% reduction in both sides is significant. You can see here the various tests which are being done. Now, what are the electrical testings which you can do for the facial nerve? Nerve excitability test. Minimal current necessary to stimulate the muscle movement when applied to a branch of the facial nerve. A difference of 3.5 milliamperes or greater between two sides is thought to be significant. So, maximum stimulation test, strength and duration of stimulation is gradually increased from 1 milliampere to the 5 milliamperes, and it's useless less than 72 hours. So, what is ENG? Electroneuronography. Action potential develops in the muscles by stimulation of the nerve is measured and expressed as percentage of degeneration compared to normal side. Surgical intervention in case of immediate paralysis with greater than 90% degeneration. No use less than 72 hours. Now, I think we will actually not describe too much about it. So, electromyographic testing also is very important, and it shows evidence of degeneration, fibrillation after 10 to 14 days, and if there are early signs of reinnervation, polyphasic innervation potentials after 4 to 6 weeks. So, you should also know about this electromyography, evoked electromyography, EEMG, or evoked electroneuronography, ENOG. So, these are all the tests which you have to do, and you have to write in your exam. So, ENOG response less than 10% of normal in first 3 weeks is poor prognosis, greater than 90% of normal within 3 weeks of onset, 80 to 100% probability of recovery. So, advantage is reliable, disadvantage is uncomfortable, cost and retest variability and things like that. So, you can see this, of course, it has been taken from standard textbook so this is all Shambo. So, we have taken this from Shambo. So, of course, they might ask you about the limitations of electrophysiological testing and what is the imaging. So, imaging, as you know, we already discussed about the MRI and the CT scan. So, I'm going to skip all these. Just answer this. So, Bell's palsy, this can be a short notes to you. It was first described by Sir Charles Bell. Bell's palsy is certainly the most common cause of facial paralysis worldwide. So, here we are, the Bell's palsy, the facial nerve. You can see the smoothing of the forehead, inability to close the eyelid, and drooling of the mouth, of the corner of the mouth. So, something about the Bell's palsy. It's a spontaneous idiopathic lower motor neuron facial palsy. Incidence is around 20-30 patients per 1 lakh population, 100,000 population. The incidence is greater in, older than 65 years and lower in children younger than 13 years. Male to female ratio of Bell's palsy are approximately equal. Left and right sides of the face are equally involved in Bell's palsy. It's a diagnosis of exclusion. Please understand, it's a diagnosis of exclusion, and paralysis or paresis of all muscle groups on one side of the face, sudden onset, absence of signs of central nervous system disease, absence of signs of ear disease. If it persists, usually it recovers, 70% will have a complete paralysis, bilateral paralysis occurs, and 0.3% has a history of previous paralysis. A family history of Bell's palsy can be elicited in 8% of patients. So the main cause of Bell's palsy is latent herpes virus. Herpes simplex virus type 1 and herpes simplex zoster virus, which are reactivated from cranial nerve ganglia. An edema of the nerve within the inelastic facial fallopian canal. Recovery begins by 3 weeks. Full recovery by 6 months. So, of course, Ramsay-Hunt syndrome is another short notes for you. You should read about Ramsay-Hunt syndrome. Also, you have herpes zoster, and you have various grades. You can read that from Mawson's textbook. It's a beautiful description which has been given. Various stages of herpes zoster. Of course, congenital facial palsy also is another topic which can be what is Mobius syndrome. So Mobius syndrome represents a broad spectrum of clinical pathological findings ranging from isolated unilateral facial palsy, usually associated with 6th cranial nerve palsy, to bilateral absence of facial nerve, abducent nerve functions. One important question which can be asked in Viva, enumerate the cause of bilateral facial palsy. So this is very important. This is what you have to tell. Mobius syndrome, Guillain-Barré syndrome, myotonic dystrophy, skull trauma, infectious mononucleosis, cytomegalovirus infection, acute porphyria, botulism, Lyme disease, Bell's herpes simplex. So this is a very important Viva question. In fact, I was asked in my MS Viva, what are the cause of bilateral facial palsy? So when it came to this topic, they asked me this question. So traumatic facial palsy is the second most commonest cause. Of course, this is another short notes. Temple bone fracture, longitudinal and transverse. Longitudinal is 70 to 90%, and of course, hemotympanum will be seen. Ossicular chain disruption, and external canal you will have bleeding sometimes. Facial nerve paralysis is only 10 to 20%, and it's mostly in the horizontal segment. Whereas a transverse fracture is present 10 to 30%. It's due to the occipital trauma. Sensorineural hearing loss and vestibular dysfunction can occur in transverse fracture. And facial nerve palsy is in 50% of individuals in labyrinthine segment. It can be from internal acoustic meatus to the horizontal segment. This is very, very important. You can see the longitudinal fracture, transverse fracture. So this again can be a short notes for you about the various kinds of fractures of the temple bone. And what about iatrogenic? Most common overall surgery of facial nerve is parotidectomy. Most common autological procedure with facial nerve palsy is mastectomy, 55%, tympanoplasty, 14%. Mechanism, direct mechanical injury or heat generated from drilling. That's why whenever we use a diamond drill, we always use, we tell the staff to irrigate more. So you have to have a copious irrigation, or else the heat of the drill can cause a facial palsy. So what is the most common area of injury? We already discussed. It is distal tympanic segment, including the second geno, followed by mastoid segment. So that is the commonest. Surgical management, of course, facial nerve decompression, neurorrhaphy, nerve transposition, hypoglossal facial, muscle transposition, temporalis masseter, and microneurovascular flap, muscle flap, and static procedures like eye implant. This all will show surgeries. All this I have done here in Royal Pearl. We can show you facial nerve decompression. Of course, we can show you all the kinds of end-to-end anastomosis, as well as interposition grafts, facial hypoglossal. Of course, now we do the masseter facial anastomosis. That also I can show you. And of course, this is the pre-operative planning. We have protocol and site to be explored based on facial palsy and expected site. All this. We have various approaches to do a surgical decompression: transmastoid, middle cranial fossa approach, and translabyrinthine approach. So what are the indications? Tumors limited to mastoid and tympanic segments, transmastoid approach, longitudinal fractures. That's a little controversial topic. AOM, COM, and involving tympanic segment and mastoid segment. Limited access to the geniculate ganglion, no access to labyrinthine segment. Now they also do the anterior approach. Of course, we will discuss that as a separate topic. So now I think we will now go on. We will not discuss all the approaches because it'll take a lot of time. Let us go on to the each one. We have described the steps. Of course, these are all the kinds of dissection of the facial nerve, and of course a brilliant dissection which has been done. It's taken from a book, not our dissection specimen. Now, facial nerve reanimation is another exam question which can be asked. Assessment and planning, cause of facial palsy. Of course, the primary end-to-end anastomosis can be performed with a defect of 17 millimeters. So, extratemporal repair can be performed less than 72 hours of injury. Most common methods of group fascicular repair, epidural repair. And primary nerve repair, severed ends of the nerve exposed and devitalized tissue are cut with a fine. We use the blade to cut it small bits of epidural sheath approximated with. We generally use the fibrin glue. Just we put the fibrin glue, and we generally now we don't even suture the nerve. Okay, now coming to nerve repair, the slide will tell you all about it. Of course, interposition grafts, the clinical use of interposition grafts in radical keratectomy, temporal bone resection, traumatic avulsion, CP angle tumor surgery. And what are the grafts which can be used? This can be an exam question for you. The auricular, greater auricular nerve, the sural nerve. These are the two nerves I have used very commonly. Of course, the sensory nerves from the superficial cervical plexus and the medial antibranchial cutaneous nerve can also be used. But I have not used these two. Only the greater auricular and sural nerve we generally use. So they will ask you about the greater auricular nerve, the surface landmarks. So read about it. So you can see here it's in a single incision. You can actually you can just extend that incision and get that nerve. Of course, sural nerve also we have done a lot of cases of sural nerve because the length is, you can have a big length. So from the sural nerve, and of course not going to describe the facial hypoglossal anastomosis. I will show you videos of that which we did a long time back. Of course, now we have done masseter facial anastomosis, cross facial nerve grafting with the sural nerve can be done. Of course, the techniques, I don't want to pull it too much. Now we have what is called dynamic slings, Aka slings, and when to use the facial neurovascular system, absent and all this stuff, and temporalis muscle which can be used to reanimate. So what is the summary? We have already done 1 hour 35 minutes of this lecture. The summary is facial palsy acute, less than 3 weeks, the seventh nerve decompression, the nerve repair, primary cable graft. So this is a very important flow chart. You have to remember intermediate, acute, intermediate and chronic. Greater than 2 years, you always do a muscle transfer or a free muscle transfer like the gracilis, serratus and the latissimus dorsi and the pec minor. So, so these are all the varieties of reanimation. So I think we have covered quite a bit of facial nerve. Of course, the surgical aspects I will definitely cover in a separate topic. Each of the surgeries of the facial nerve we will try to discuss. We will try to completely cover all the surgeries pertaining to the facial nerve. I promise that this will all be dealt in the subsequent classrooms. But tomorrow, as I told you, we have a very major case in the night, so we will not be able to give you a class because I'm doing olfactory groove meningioma for a doctor, and so I'm sorry, tomorrow we are not there. But day after tomorrow night at 9 o'clock, we're going to deal with pharyngeal arches and pharyngeal pouches. So that is going to be a very important essay question for you for MS PGs. So with that, I want to say goodbye and thank you and good night. And of course, you can revise this class again and again. It's very important. We discussed several topics pertaining to the facial nerve, and I hope you enjoyed the class as well. And you can actually, you know what, you can read your book now. It'll be easier, or you can actually take points from these slides. This class will always be available on my timeline. We will not remove these classrooms. This is going to be a series of episodes of Coffee with Janki. And thank you very much, my dear postgraduates. If you have any questions, I am ready to answer the questions for you. So we will wait for the postgraduates. We'll see who are all online. So Matthew Jackson, thank you. Asaduzam Rosal, I don't know from which country, but thank you very much. Poonam Verma, Deepshika Mishra Thakur, love the class. Disha Metwani, oh, you're still there, Dr. Disha. You're a rhinologist, but you're also interested in otology. Good. Basically, I love otology, but only thing is I don't demonstrate my otology because I want to project myself as a rhinologist. That's the actual idea. But I will plan to demonstrate my otological work. I love demonstrating otology. In fact, I started my career as an otologist. So Naveed Gul, Sinjo Thomas. So it's been a pleasure to have you all here with me. And Manasa Devaraj, Usha Armo, Pankaj Chauhan, Naveed Gul, and yeah, lovely Tamil Silambu. Yeah, maybe Tamilian. So thank you very much. Good night, my dear friends, and have a nice day. Thank you. Bye-bye.
Okay, thank you, Naran, excellent ENT teacher. He's doing a series on oh, hold on, I gotta, okay, so you gotta watch the sound on these webcasts when you share the screen. There was a lack of sound in the first part of the video, but we're learning. So anyways, I'm excited to have an ENT studio. He's a dedicated teacher. It took more than an hour and a half to teach at 9 p.m. at night. So we're going to end this. Thank you very much. See you next Saturday. He's going to do a class. However, we have 3 conferences. We have one at 8 a.m. with Japan. We have a webinar on neurosurgery innovations put together by Dr. Kato, a famous vascular surgeon from Japan. And at 10 a.m., we have Art in Medicine from the European Student Think Tank at 10 o'clock Eastern Time. And at, let's see, the last webcast is from Africa. It's a webcast by Nathalie Gothi, a medical student from Cameroon, currently doing a residency in the Ivory Coast. So we'll see you Saturday.